Welcome here in this session on high-dose rifampicin, the treatment of tuberculosis. I'm very happy that these number of people are here now, because when we started to think about higher dose of rifampicin, about, 8, 9, 10 years ago, we also had Symposium and there were only 5 people interested. So either there are a lot of believers or a lot of skeptics, but we'll see and we'll discuss. Can I just ask everybody to switch off the mobile telephone or the sound of the mobile telephone? Thank you very much. And also, nice and proud to announce that just today, coincidentally, in the Lancet Infectious Disease, there's a paper from our group on high-dose rifampicin, 35 milligram per kg for 3 months, the so-called MAMS trial together. Also, we research SK109 and Moxifloxacin, and I invite everybody to look at that paper because it's interesting. So today we'll start with a session. And first, I would like to invite Jerry Davis from the University of Liverpool. Jerry is already some longer time in the business of high-dose rifampicin, and especially on the bacteriological outcome. And he will brief us on high-dose rifampicin in pulmonary tuberculosis.
Thank you very much, Martin. Well, I must say it is a great pleasure to be invited to give this talk on behalf of almost everybody else who's been in the high-dose development teams. So I'll just preface what I'm going to say with the standard declaration of COI, of which I have none. In the beginning, an Italian chemist, Piero Sensi, created rifampicin, and we saw that it was good. Here on this slide, I'm just summarizing very briefly pretty much the outcome of almost all the trials that were done by the British MRC in East Africa during the 1970s, the trials which resulted in modern short-course chemotherapy as we know it today. So on the left there, you can see the first trial in which a prototypical short-course regimen was used, rifampicin and pyrazinamide being used together for the first time, and at a stroke, reducing the duration of therapy from 12 to 18 months to 6 months. And on the right there, you can see the trial that shortly followed after on the heels of that, the notorious fourth collaborative study, or Study X, in which, by using those drugs, the team attempted to reduce the duration of therapy to only 4 months and roundly failed. So all 5 of those regimens had relapse rates that were unacceptably high, showing that at least those 2 drugs in combination, at least at those doses, were not capable of significantly shortening treatment of drug-sensitive disease any further. And as time has gone on, we look back on the results of those trials. It's evident that there was a pause of more than 30 years, really, before anybody stopped to re-examine the possibility of changing that regimen. And we can discuss later some of the many reasons why a dose of 600 or 10 milligrams per kilogram was chosen. But there was a lack of concerted drug development over a period of years in the early phase. And there were also considerations of cost, which seems to make it unacceptably expensive for widespread use in developing countries. But looking back, all along there has been evidence that the more rifampicin you have, the better. And so here I'm just summarizing data from, that table's gone a bit strange, data from a couple of papers. On the right, perhaps the one to start with is International Union Study A, conducted by Amina Jindani, which showed pretty conclusively that giving rifampicin throughout therapy is essential to achieving low relapse rates at a duration of 6 months. So really, rifampicin is the key cornerstone of short-course chemotherapy and achieving good results at those durations. And on the left, you can see the results of a systematic review, which was carried out by Dick Menzies' group, and published in 2009, which again essentially shows that the longer you have rifampicin for, the better that is in terms of reducing the relapse rate after treatment is stopped. But the history of rifampicin development and deployment is, I think, an unhappy one. How could we be standing here 40 years after the fact and still not know whether the dose of rifampicin that we're using is the right one? Furthermore, how could we be in a situation where the one drug that we know is essential to short-course chemotherapy is a drug for which there now exists globally a significant prevalence of resistance? In some countries, the ones that many of you, in fact, work in, the prevalence of primary MDR-TB, or primary rifampicin resistance, is in excess of 10 or 20%. So how did we get here? Well, for the last 10 years, a number of groups have been, and many people who are sitting in the audience today, have been looking back at the preclinical evidence and trying to decide how it was that we selected the dose of rifampicin that we currently have today. And perhaps this is the slide that best summarizes that issue. This is work, very extensive work and detailed work that was carried out by the AstraZeneca group in Bangalore and published in 2003 by Ramesh Jayaram. And here you can see three curves, three concentration response curves. On the extreme left, you can see a dotted line which relates to in vitro experiments. And you can see on the log scale at the bottom that as the total exposure of rifampicin in relation to the minimum inhibitory concentration rises, the effect also increases. And it keeps on increasing, even up to concentrations of AUC-MIC in excess of 1,000, 2,000, 5,000. And you can also see two solid curves there. The solid curve is conducted in intracellular infection models, so inside macrophages infected with TB. And you can see that the response, though it's shifted to the right, is essentially the same pattern. And most concerningly, at the bottom there, you can see the long dashed line. Those are results, very extensive experiments that were carried out in mice. Dose fractionation experiments designed to establish what the PK-PD driver was of that effect, and showing again that even up to AUC-MIC values of well in excess of 1,000, the response is still increasing. Now, in case anybody is wondering what that means, it's probably worth noting that in general, the kind of values that we achieve in patients in terms of PK-PD are generally of the order of perhaps 80, 100, 150. And if you orientate yourself on that graph, you can see that the kind of response you would expect in these in vitro and in vivo systems is clearly suboptimal. And so it was reviewing this data that made a lot of people take a step back and decide that the clinical development of rifampicin needed to be reviewed. And here is some data just really summarizing a lot of the historical early bactericidal data studies. These are phase 2A studies based on counting colonies in sputum on monotherapy in newly diagnosed patients. And to summarize this plot briefly, the doses are increasing steadily down the plot in the substrata. And what you see is that from doses of approximately 3 milligrams per kilogram up to 12 milligrams per kilogram and finally up to 20 milligrams per kilogram, you see a continuously increasing value of early bactericidal activity, suggesting that the current dose certainly does not achieve optimal early bactericidal activity, which gives us some pause that perhaps we're not using the dose that will also achieve optimal sterilizing activity. And that line of thinking led Andreas Diakon and others in Stellenbosch to conduct some new EBA studies in the early 2000s in which they essentially doubled the dose of rifampicin to see whether or not the preclinical data was correct in suggesting that the human dose is quite low on the dose-response curve. And indeed, what happened was that doubling the dose approximately doubles the EBA. This is now 10 years ago, note. So, the upshot of all of that was that several groups decided that something had to be done about renewing clinical development of rifampicin. And one of the first groups to do that were Martin Bure and Rob Arnautzer, one of the founding members of the Panacea Consortium. And you can see here one of the first studies that they performed, which was now published a couple of years ago, in which they did what's called a maximum tolerated dose study. So they increased the dose of rifampicin by 5 milligrams per kilogram increments in patient cohorts of 15, and they examined both the PK, the safety, and also the efficacy at a relatively low statistical power of these new doses of the drug. And Perhaps unsurprisingly, but concerningly, what they discovered was, given what we know about the pharmacokinetics of rifampicin, they discovered that the increases in exposure were in fact more than dose proportional. So in humans, it wasn't very difficult to achieve very high plasma exposures. Happily, that appeared to be safe and did not result in an increase in adverse events. And it also appeared to generate a statistically non-significant trend in EBA. So you can see that at the much higher doses of 30 to 35 milligrams per kilogram, the EBA appeared to be increased in this small study. What you'll also note is that up to doses of 25 milligrams per kilogram, there didn't seem to be much of an effect. That study is not, I should say, and Martin will expect me to say this, that study is not yet complete, and I will re-emphasize later that we still do not know what the maximum tolerated dose of rifampicin actually is, but this is the data that's in the public domain so far. Another approach was simply to see not whether rifampicin worked better, but whether it was safe to take more rifampicin. And this was an approach taken by the INTER-TB group, led by Amina Jindani, who conducted the RIFATOX study. And the RIFATOX study was a very simple idea, essentially to evaluate two higher doses of rifampicin at 15 milligrams per kilogram and 20 milligrams per kilogram in 100 patients per arm in several centers, particularly in Uganda and in Latin America. And you can see here the headline results, really, of that trial, which essentially showed that the number of grade 3 or 4 increases in transaminases were in fact very few, and that the number of adverse events, particularly those relating to hepatotoxicity, were essentially zero in terms of serious adverse events. I will note that those were measured using the DAIDS criteria, where transaminases are considered to be abnormal at greater than 5 times the upper limit of normal. So this was another study that seemed to give people confidence that actually increasing the dose of rifampicin could be done safely. And there are a number of other studies that have now been published or are in the public domain, and here's my attempt to summarize them. So I'll just take you through this plot gently. What you can see here are the risk differences in terms of 2-month culture conversion for a number of phase 2b studies of rifampicin, and I've also chosen to compare it with rifapentine, which of course there's a parallel development program going on in TBTC to increase the dose of rifapentine, and it's quite interesting to compare the results. So though in study 29X, which was a dose escalation study designed to find the optimal dose of rifapentine, there was a suggestion that at 20 milligrams per kilogram of rifapentine, there was a significant increase in culture conversion at 2 months. None of the studies with rifampicin to date have been able to replicate that for rifampicin at the same dose. So you can see here the results of the RIFATOX trial, the results of the HIRIF-2 study, which Martin Burry and Rob Arnautz conducted, and most recently, the HIRIF study conducted in Lima, Peru, by myself and Carol Mitnick. And you can see that none of those risks appear to show definitive evidence of efficacy for RIF, at least at the dose of 20 milligrams per kilogram. So it's fortunate indeed that the Panacea group weren't really satisfied with the doses which were approved for those initial trials. So the trials that I've just shown you were somewhat conventional trials in the sense that they used an accepted regulatory endpoint of 2-month culture conversion, and they used doses that were, we now know looking back, perhaps not as high as they could have been. They're certainly safe, but perhaps they weren't likely to be efficacious. So Martin referred to the publication of the MAMS-TB trial. This is an earlier iteration of those results. But essentially the structure of the trial, I think many of you are familiar with it, is an adaptive, multi-arm, multi-stage design which evaluated 4 test regimens. And among those test regimens were regimens that included rifampicin at 20 milligrams per kilogram and an arm that went up to 35 milligrams per kilogram. And the results were, I don't hesitate to say, dramatic. So a couple of the arms were dropped at an earlier stage at an interim review because they performed poorly, largely the arms including SQ109. But the arm including rifampicin at 35 milligrams per kilogram did result in accelerated culture conversion over a 3-month period, the results of which you can see here, a 70% increase in the risk, in the hazard of culture conversion, which was a statistically significant finding. And in fact, if you rescale the Cox model to a 2-month set of observations, what you find is that the increase in the hazard ratio is approximately 2-fold, which is a very dramatic effect, the largest increase in culture conversion that has ever been seen, in fact, in a phase 2b trial in tuberculosis. So these results are very exciting, and I think that they give us confidence that higher doses of rifampicin could be effective, and indeed the 35 milligrams per kilogram dose is being taken forward by the Inter-TB group with funding from the MRC to conduct a phase 3 trial to see whether that dose is truly capable of shortening therapy. So I contend that rifampicin remains unsurpassed in efficacy amongst first-line drugs. I think that that is self-evidently true. And that historically, the deployment of rifampicin-based regimens was highly unsatisfactory in retrospect. I don't think anybody's blaming anyone about that, but how can we be here 40 years later and still not really know what the right dose is? We still don't know what the right dose is. That trial is continuing, but there is some evidence of increased clinical efficacy at higher doses, and we hope that there will be more very soon. And so rifampicin really remains, I think, a feasible and a highly desirable route in many respects because of its cost to treatment shortening and perhaps also to the prevention of further dissemination of rifampicin resistance. So I'll stop there, Martin.
Thank you. Well, thank you very much, Jerry. That was nice and good. So we'll have a discussion at the end of this session, but because I can allow 1 or 2 questions for now.
If anybody has any.
I think you were completely clear, Jerry. Okay, thank you. We'll save your questions then for the panel discussion. Thanks very much. Okay, we move on with the next speaker, Kelly Dooley. She's from Johns Hopkins University, Baltimore, and she will speak on drug-drug interactions with rifampicin and implications for its use with new anti-TB drugs and HIV co-infected TB patients. Kelly.
Great, thank you. Well, good morning. It's nice to see a lot of friendly faces in the audience, and it's nice to see actually that this seems to be a standing room only session. So that just tells us there's a lot of interest in high-dose rifamycins, which I, of course, really like to see. It was very nice also of Jerry to start off the session by introducing high-dose rifamycins and the promise for treatment shortening and potentially prevention of drug resistance. So I'm going to talk a little bit about drug-drug interactions with rifampicin. So first off, I mean, Jerry introduced this very well, but the question to begin with is, why do we care about drug-drug interactions with high-dose rifamycins? And so he showed you the evidence from long ago and then more recently that higher doses of rifamycins appear to have improved efficacy if you use them right and at the right doses. And so he showed you from the Panacea MAMS trial that if you increase the dose of rifampin from 10 to 35 milligrams per kilogram, you get an increase in culture conversion and other endpoints that they measured in the trial. And also, if you substitute rifampin for rifapentine, a highly potent other rifamycin, and you give it at a high dose, you also have high rates of culture conversion. In TB meningitis, the group in Bandung, Indonesia, showed very nicely that if you give a higher dose of rifampin and you give it in an IV formulation, that you can reduce mortality with TB meningitis by about 50% in a relatively small trial. And then there have been recent data presented but not yet published showing that if you increase the dose of rifampin among patients that have TB and HIV, that have advanced HIV with low CD4 counts, that there actually appeared to be a mortality benefit that was not even related to starting antiretrovirals antiretroviral treatment in those patients. So it seems that there's several lines of evidence to suggest that higher doses of rifamycins are better for preventing mortality in some populations and perhaps for treatment shortening in other populations. So we love rifamycins, and certainly it's the key sterilizing drug in our regimens, and so far it has been irreplaceable. And so we love this drug, but in some ways we also struggle with this drug because of its risk for drug-drug interactions. And so this drug is a very potent inducer of multiple metabolizing enzymes. Those include hepatic enzymes, so the P450 enzymes you may have heard about, and then also phase 2 enzymes as well as transporters of drugs. And it does this in a rather promiscuous fashion. And so as we bring up the rifamycin doses, then what's going to happen in terms of induction of these metabolizing enzymes and inductions of these transporters, and therefore what will happen to the concentrations of companion drugs, and indeed the efficacy of drugs that we like to use in patients that have TB but also have other diseases such as diabetes or HIV or other common comorbidities. And so I'll just talk a little bit about HIV because we know that patients with HIV bear a disproportionate share of the TB burden. And so for now, what drug combinations can we use in TB HIV co-infected patients? We know that we can use efavirenz quite nicely with rifampin with no sorts of dose adjustments. There are now integrase inhibitors that are becoming more available globally that you can use safely with rifampin, although you do need to adjust the dose of the integrase inhibitor to double to achieve reasonable concentrations and good virologic suppression. And so, so we essentially have relatively few treatment options for the TB HIV co-infected patient. And if we're going to bring up the rifamycins, we really would like high-dose rifamycins to be available to all TB patients, including those patients that also have HIV. And so then what's going to happen if we double the dose of rifampin? Or, in fact, if we take the dose of rifampin from 10 milligrams per kilogram to 35 milligrams per kilogram, what's going to happen to the companion drugs? And so this is how a pharmacologist looks at the human body. So it's maybe a little bit simplified, but essentially, you know, we have this idea, you know, you swallow a medicine and by some sort of a magical process, it cures you or it makes you feel better or something along these lines. But in fact, what happens, you swallow the medicine and the medicine has to be absorbed across the gut. And there are transporters that are involved in that. And then the drug is transported to your liver where further metabolism happens, and then it enters the bloodstream, travels out to the tissues in the site of disease, and then again it travels back to the liver for further metabolism and then is excreted in the urine or through the liver and in the feces. So it's a complicated process, and so there are many different levels on which you can have drug interactions, and in fact rifampin is involved in most of these in terms of absorption. If you upregulate a PGP, P-glycoprotein, then you may impact on absorption of a drug. If you upregulate phase CYP3A or other CYP P450 enzymes, then you may impact the metabolism of drugs. And then also rifampin acts on some of the transporters in the kidney to impact on clearance of the drug through the kidneys. And so then you have so many different drugs that people take, obviously, and there are many different pathways that drugs take to be metabolized or to be cleared. And so then how might you predict, because you can't do every experiment of every drug together with a higher dose of a rifamycin, for instance, so how might you predict what some of the drug interactions will be for those key drug interactions that you care about? And so this is just to show you. So essentially what you do is you start out with some in vitro models and you look to see what the relationship is between drug concentrations in these in vitro models and transcription of these mRNA or these metabolizing enzymes expression. And so you can see that for the rifamycins, there's a relationship between the exposure of the drug and the expression of this mRNA. And so that goes into these models that people build, these physiologically based PK models, in which if you know how your drug in particular, if its metabolic pathway, and then you know the relationship between the rifamycin and the induction of metabolizing enzymes, then you can understand using these models what you think are likely to be the impact of things. So Ian Gardner from Certara, who works with the SimCip program, was kind enough to do a couple of simulations for me. And essentially, this is, just as an example, midazolam is a drug that is cleared by CYP3A. So it's a probe drug that we use to look at how different drugs impact this particular metabolizing system. And so he did some simulations where if you take rifampin at 10 milligrams per kilogram every day for 14 days, then you will have a 92% reduction in your midazolam concentrations. And if you, on the other hand, take rifampin at a dose of 35 milligrams per kilogram for that same time period, you have about a 90% reduction in the concentrations of midazolam. So certainly you would imagine with a 90% reduction that midazolam is not going to be a very effective drug. And so this is the kind of, if you think of protease inhibitors, they're cleared by CYP3A. So you would imagine you're going to see a pretty similar thing with boosted protease inhibitors together with either standard dose of rifampin or high doses of rifampin. And so then if you go further and you do a similar experiment, but now for CYP2B6, which is the primary metabolizing enzyme for efavirenz, then you can see in the left panel the drug concentrations of efavirenz. And in green are efavirenz by itself, and then in black are efavirenz if you give it together just with rifampin. And again, remember, this is a virtual experiment done in silico by a computer, but this would predict that you have about a 30% reduction in your efavirenz concentrations if you give it together with a dose of 10 milligrams per kilogram of rifampin by itself without the other drugs that you typically use for TB. And then if you do the same experiment and you just increase the dose to 35 milligrams per kilogram, you also have about a 70% decrease. So this is actually nice, at least in silico data, that would suggest that as we increase the dose, that efavirenz concentrations are not going to be further reduced or meaningfully reduced by increasing that rifamycin. So we've maxed out the effects of rifampin at 10 mg per kg, more or less, on this particular metabolizing enzyme. And so then sometimes you don't really know, you don't have these model systems in vitro in livers that are in these PBPK models, and so you have to try to figure out what you think these drug interactions might be just based on experimental data from patients who have taken the drugs together in the context of different trials. And so this is some data, just a simulation by Radha Savage showing, well, what would be the impact of having rifapentine, so it's a cousin drug to rifampin together with moxifloxacin. And so if you give a dose of rifapentine that is a 10 milligrams per kilogram dose, you may have a 30% increase in clearance of moxifloxacin, whereas if you give a 20 milligram per kilogram dose or 1,200 milligrams, then you're going to have more like a 50% reduction in moxifloxacin concentrations. And so this is relevant because those drugs are being used together in a phase 3 trial to try to shorten the treatment for tuberculosis. And so even though these models still need to be proven in patients who are taking the drugs, this gives you some idea of what you might expect in the trials. Okay, and so then you do these in silico experiments, and then you run what we would call, the wet experiment, which is among patients who have both diseases and are taking both sets of medicines to look at the, and so you can see here that when you take rifampin together with efavirenz, both at standard doses, you don't actually have any reduction in efavirenz concentrations, and that's probably because people who take rifampin also take isoniazid and pyrazinamide and ethambutol, but isoniazid blocks blocks one of the metabolizing enzymes for efavirenz, whereas rifampin ramps up another pathway. And so together, the overall effect is that really there's not a reduction. And so now the question is, okay, well, in patients who are now receiving higher doses of rifamycin, so 20 milligrams per kilogram, or indeed 35 milligrams per kilogram, will efavirenz concentrations be preserved? And this will be shown, or this is being tested in the rifampicin trial, which I think is close to the end of enrollment and will be reported in early 2017. And then, well, what about other HIV medicines? Dolutegravir and raltegravir are good drugs to use together with standard dose of rifampin. We don't actually know what will happen if we increase the dose of rifampin to 20 or to 35 milligrams per kilogram. And so those experiments still need to be done. There really aren't good in vitro models of the enzymes that metabolize dolutegravir and raltegravir, particular this UGT1A1 enzyme. So these are experiments that still need to be done, I think. And so they wanted to talk a little bit about new drugs, and this is the only slide I have about that, but essentially just showing that rifampin with pratominid reduces the concentrations of pratominid by about 66%, that when you use rifampin with bedaquiline is reduced by about the same, and that if you give rifampin at the same time as you give delaminid, that you have reduced concentrations of delaminid, but not higher exposures of metabolites, so it's unclear if this was an absorption issue or in fact a metabolic drug interaction. But whether or not these interactions could potentially be mitigated with dosing is something that we don't know and is not currently being explored. So in summary, rifamycin antibiotics, they're highly potent anti-TB drugs that up to now are irreplaceable. And so we have to use them, and we have good evidence that higher doses of rifamycins can improve outcomes, at least in some patients. And we think that it's a promising key component for treatment shortening regimens for drug-sensitive TB. However, rifampin, as we know, is a very potent inducer of multiple metabolizing enzymes and transporters, and so we need to learn better how the increase in dose is going to impact on potential drug interactions with medicines we care about or that are commonly used in patients with TB. The methods there are some methods to predict these so that you can run the trials that you need to run in a smart way and try to mitigate the drug interactions from the beginning in the design phase of these trials. And then you can confirm or test the doses in patients who are taking both sets of medicines. We still have lack of full information about the use of high-dose rifamycin with the commonly used antiretroviral medicines, and this work still needs to be done. And I just wanted to thank Ian Gardner, who was kind enough to run these simulations for me in the last couple of days, and in fact, Rada Savage, who did the same. So I'm grateful to them, and thank you for your attention.
Thank you very much, Kelly. There's place here for the ones, because there's a lot of people standing there. All right, we have some extra time for questions, but again, we also have a panel discussion at the end, so you can save your question also to there. Just one question from me, Kelly.
Yeah.
So this was a simulation you did, 10 and 35 milligrams midazolam?
Yeah.
So do we need a trial on that?
Well, it depends on if you care about the difference of a 10 milligram per kilogram versus 35 mg per kg dose in midazolam. So if you think that many of your patients are going to be needing midazolam in your trial, then certainly you might think about that. But no, I think this just gives you some idea. And, and in fact, I think from the efavirenz modeling, what we've learned is that early on, based on model-based predictions, we thought that if you give efavirenz with rifampin, that you reduce concentrations by about 30%. And indeed, that's what was shown in the models and then was seen in healthy volunteers who only took efavirenz and rifampin. But then when they did the same experiments in patients who were taking full TB treatment and full HIV treatment, then all of these other metabolic pathways were also relevant and were impacted by the companion drugs. And then there's also, at least with efavirenz, people have different metabolizing genotypes, and so their concentrations are very variable depending on their genetic makeup. So I think to have a full complex picture of a drug interaction for drugs that will really be commonly used together, where you suspect there will be an interaction based on the metabolic pathways of both drugs, then you need to do the experiment in patients to confirm. Yeah.
All right, so the theory is that rifampicin standard dose is maximally inducing the metabolizing enzymes in the liver, and that increasing the dose will not increase that effect anymore.
It depends on the
that's
drug.
The theory. Yes.
Yeah, and so if you had like rifampin in a liver, in these liver testing systems, you can define a maximum induction, so an Emax, that you can achieve as you increase the the concentrations in the test tube, and then you can also define the EC50 and the slope of that relationship, and then so you can get a sense of if your current drug gives you a dose of X. Are you at the maximum that you can induce that particular enzyme, or where are you on the curve? So it depends on the drug, but it depends totally on what drug you're talking about.
So you can't say, okay, this is one trial, one experiment, and that proves that effect. You have to do that in each and every drug where you interact with.
Well, I think it gives you some idea. So if you see this model, you would say, okay, do we want to do a drug interaction study of protease inhibitors together with rifampin 35 mg per kg? You don't, because it's going to be wiped out. And that, you may not know exactly the magnitude of the effect, but that's a strong effect, and so that's not a drug combination that's going to work. So if you have to pick the experiments you can do, because you can do this model very quickly if you have the right tools, but in this rifampicin trial, for instance, has taken some years to complete. So you have to be really selective, and this might, I think, help you select those trials that you really want to do, that really matter, in a smart way, and design them so that you can mitigate the dose. So like for dolutegravir with rifampin, based on some modeling, they thought that the concentrations would be reduced, and so built into the initial trial, giving the drug twice a day together with rifampin, and it turned out that worked quite nicely, so that you don't just do the drug interaction, okay, it's a 50% reduction, okay, now we're going to do the experiment where we give the higher, the dose. So you can do it a little bit more smartly, but it still has to be proven because these pathways are complex, and rifampin is turning on all of these different, transporters and metabolizing enzymes. So it's hard to, you can't really build that fully in silico.
Well, thank you very much. Yeah. Very clear. I'll give over the chair to my co-chair, Carol Mitnick.
Great. Thanks, Martin. So I'm Carol Mitnick from Harvard Medical School and Partners in Health. And we're going to continue the session. There was a last-minute change. Rob Arnotza couldn't be here for personal reasons, and we're fortunate to have Reinhard van Krevel from the University of Radboud in the Netherlands to talk about high-dose rifampin and TB meningitis.
Thank you, Carol. And it's really nice to see a nice audience here. Indeed, I have the honor to present the data. And of course, this is teamwork. I'm presenting on behalf of Rob Arnouts, who's standing next to me here in a meeting in Vietnam, but also, of course, on the wonderful Indonesian team who has been doing the TB meningitis work. So TB meningitis, the most severe manifestation of TB, a disseminated form of TB associated with HIV and with immune deficiency. It's a subacute meningitis. It's in basal meningitis, and the inflammation at the base of the brain leads to entrapment of nerves and blood vessels and the fourth ventricle, and that leads to vasculitis, cranial nerve palsy, stroke, and hydrocephalus. Sometimes you see mass lesions, tuberculomas, and sometimes real sort of abscess. And it's a severe disease. This is data from the Indonesian cohort, stratified for HIV. On the left, you see the very high mortality in 1 year, 60% among the HIV infected and almost 40% in the HIV uninfected. And on the right, you see stratified by the Glasgow Coma scale, so by the severity of disease when patients are presenting. And you see, obviously, the ones that come in with more neurological manifestations have a poorer outcome. So many years ago, and because of this inflammation, I was telling someone yesterday, we give corticosteroids to these patients to try and reduce the inflammation, but it's not completely effective, and I think we need to come up with more effective host-directed strategies. But almost 10 years ago, I thought, well, let's first see if it's not antibiotics. And really, I had very low expectation that giving more antibiotics would make a difference, but that's how the story started. Because the optimal regimen, the optimal antibiotic regimens for TB meningitis has not been defined, unlike the pulmonary TB, where there's lots of trials, and of course there's advancing knowledge, and now we believe that we need to give more rifampicin. But for the meningitis, we just follow the model for the pulmonary TB with a standard 4-drug regimen, even though we know that the penetration of some of the drugs, especially rifampicin, into the cerebrospinal fluid is low. And also, you saw the picture of this man who is subconscious or unconscious and who can't swallow the drugs, and he gets the medication via a nasogastric tube. Maybe that affects the bioavailability. Maybe there's gastric paresis in these terribly ill patients. So we should be worried about drug exposure. And maybe we should increase the dose of rifampicin, and maybe we should also add more potent drugs like fluoroquinolones that have a good penetration into the brain. So this work has been done. I'm going to present you three small trials from Indonesia in a hospital in Bandung, in West Java, that sees approximately 10 cases of TB meningitis a month. The HIV co-infection rate is lower than in many other settings. It's approximately 15%. And so there has been a cohort going on for like 10 years. And first, it took us a few years to get to diagnosis right. It's very difficult to diagnose TB meningitis. Microscopy is very insensitive. And next, we focused on the antibiotic treatment. And now, I won't tell you about it today, but we focus on immunopathogenesis. So this is the design of the first trial, which had a factorial design. So first we randomized. The average body weight of a patient is 45 kg. So we randomized to standard 450 milligrams oral rifampicin or a higher dose, approximately 30 milligrams per kg of IV rifampicin. And then either a temporal or a standard or a high dose moxifloxacin in the second randomization. And this was accompanied by isoniazid, pyrazinamide, and standard dose tapering steroids over 6 weeks. This intervention was given for the first 2 weeks. So on the left, in regimen A, is the standard regimen. So 450 milligrams ethambutol, INH, pyrazinamide. And here you see 5 regimens of intensified treatment. These are the patient characteristics. We screened about 180 patients. Just for your information, we had to exclude 30 because of imminent death. That was one of the exclusion criteria. And even after randomization and before the first pharmacokinetics, we lost a few more. It's very severe. Patients, mostly the median time to death is 7 days in this cohort. So this is a typical picture of the TB meningitis patients. Here you see the HIV. 7 patients had HIV, and you see the typical findings in the cerebrospinal fluid with a mild pleocytosis, mostly mononuclear, and a high protein and a low glucose. And we were able to culture, which is actually quite a reasonable rate, we were able to culture MTB in 50% of our patients. Also important, chest X-ray abnormalities are common and are often forgotten in the diagnostic workup. So this was a study primarily focusing on the pharmacokinetics. So drugs were administered. The IV was dissolved and given over 1.5 hours. And in unconscious patient, oral medication was given on an empty stomach via the nasogastric tube. And then pharmacokinetic assessments was done at 2 days after start of treatment. And that, of course, that early time point is because so many patients die. So we needed to have pharmacokinetics early with a full curve in blood and 2 separated time points on cerebral spinal fluid for pharmacokinetics. And then we did a safety tolerability assessment, close monitoring of patients with blood and ECG. Now here, this is the curve in blood. And you see you get a disproportional increase with the higher dose IV in plasma rifampicin concentrations over time. And indeed, so if you calculate, it was about the maximum rifampicin concentration was about 3 times higher in patients on the IV dose compared to the standard oral dose. And these are the figures for the cerebrospinal fluid. And there is an increase, approximately 2-fold increase. And you see here, though, that the actual concentration of rifampicin in the cerebrospinal fluid is much, much lower, taking in mind that this is the free unbound concentration of rifampicin, so you cannot really say it's just 4% of the blood, but it's much lower than in the blood. Moxifloxacin, we found a higher concentration in blood and in CSF, and you see that the moxifloxacin has a much better penetration into the cerebrospinal fluid. Side effects and toxicity, so these are the 3 arms with the higher dose of rifampicin, and to cut a long story short, there were no, I mean, these patients very often have liver dysfunction when you start treatment, even before you give antibiotics, and also many had some QT prolongation, and we corrected potassium and we did other things, but basically there were no differences between the groups. And you should be very careful to stop TB treatment in a TB meningitis. Just close your eyes when you look at the lab and continue your treatment, because you are going to lose your patient if you don't. And this is, of course, you saw the graph in Kelly's presentation. So the intervention was given for the first 2 weeks. This is in the total group, and you see here the reduction in mortality with the higher dose intravenous rifampicin. Again, you see the very high mortality early on. After start of treatment, and this is in the 30 patients that had culture-confirmed, 31 patients that had culture-confirmed TB meningitis. So obviously we were excited about this. If you look in Cox regression, what determines the survival? Well, I showed you the graphs in the beginning. Obviously the neurological state of the patients when you start treatment, the Glasgow Coma Scale, is very important, and that was strongly associated with survival. But also the adjusted for that, the rifampicin, the intervention with rifampicin was clearly associated with better outcome, while there was no such relation for the moxifloxacin. So concluding that this intervention is safe, leads to much better drug exposure, both in blood and cerebrospinal fluid, and lower mortality. And that based on these data for the moxifloxacin, it seems safe and it leads to very good exposure, but that we can't be sure whether it has any benefit. And these data were published by Dr. Rizal, the neurologist, and Dr. Ruslami, the pharmacologist, who were leading the trial in Bandung. So following on this first trial, and I'm going to describe them just briefly, we did 2 additional studies. One of the main questions we got after this first study was the use of intravenous rifampicin. It was not trivial to get it into the country in Indonesia and to use it, and we got questions from many other sites. Can you get a similar result with oral rifampicin, because we can't prescribe IV rifampicin? So we did a pharmacokinetic study in 30 patients with the 600 milligram IV dose and 2 higher oral doses, so the 900 milligram equivalent of 20 milligrams per kg, and we did pharmacokinetics in blood and CSF. And the higher dose oral led to similar AUC, lower Cmax. That, of course, has to deal with the rapid infusion of IV rifampicin. And based on these results, we're currently doing a study where, and of course also on the newer data from the African studies, we are now doing a study which is almost completed with 3 doses of oral rifampicin. Now, I'm sure many of you read the paper from the Vietnam trial earlier this year in New England. They used a phase 3 study, and they used a much lower dose, 50 milligrams orally versus 10 milligram, and they combined it with levofloxacin, which was actually added to the standard regimen. And they gave this intensified regimen for the first 2 months of treatment. And this is the survival curve of that large trial, and you see that there's no difference between the intensified treatment and the standard treatment. You also see that the mortality in this cohort is lower than in ours. In Bandung, the neurological severity at time of presentation was a bit milder in this trial. So how can we explain this difference? Well, dose is critical because following on this first study where we just looked at dose and outcome, we also looked at the actual concentration effect relationship. And here you see when you take the mortality at 2 weeks or when you take the mortality at 6 weeks and you link that with the rifampicin exposure, you see that there's a clear relation between exposure and outcome. And that is also true for the cerebrospinal fluid concentrations. This is work done by Lindsay de Brake in the Department of Clinical Pharmacy in Nijmegen together with Sofiati Dian in Bandung, published last year. And also when you based on these data, we could sort of calculate the minimum threshold. So the minimum threshold for this effect, and we can't see what happens further on the curve, but the minimum threshold for rifampicin seemed to be 22 milligrams per liter as a Cmax. And this is not just true for the blood, but also for the CSF. Where similarly you find a clear relation between concentration and outcome. And based on this and based on modeling from Radosavic's group, it seems that with our dose we didn't even go high enough and that only 38% of our patients actually reached that minimum threshold and that the remaining, that the other patients are still below that minimum threshold and that we should be more aggressive in our treatment. About 10 years ago, we did the first study in pulmonary TB with a high-dose rifampicin, and we spoke a long time to go from 450 milligrams to 600 milligrams, and people were really concerned about safety. So I'm glad we can now see that we can treat patients with 35 milligrams per kg. Modeling here also for the pediatric, so taking these data and other data to model what the concentration should be in kids, and here also for pediatric TB meningitis, the required dose, according to this modeling, is at least 30 milligrams orally or 50 milligrams IV. So my next patient who comes with ICU with a TB meningitis, I will treat him very aggressively with 20 milligrams per kg IV, with INH IV, with Moxifloxacin IV, with amikacin and pyrazinamide. Of course, this is expert opinion. We need more evidence, and we also need a good clinical trial on TB meningitis in Africa. We have a very good protocol, so if anyone's willing to fund us, we can do it in 5 sites and start next month in 4 different countries in sub-Saharan Africa. But I think this is the way to go forward. There's a lot of people, obviously, who contributed to this work and to the beautiful collaboration that has been ongoing with the Indonesian side for the last 18 years. Thank you.
Thanks so much, Renaud, and especially for stepping in at the last minute. We really appreciate it. Are there questions specific? Yes, please, go ahead.
Yeah, so the first question is whether we compared 450, if I understand you correctly, whether we compared 450 milligrams orally and 450 milligrams IV?
600 milligrams IV with 450 milligrams IV. Because 450 milligrams IV did not appear in your study.
No, we never considered that. I mean, I think the ampules are 600 milligrams, and we wanted to make a step. And of course, one was dose, and the other thing is that we were concerned, I didn't show you, let's say whether there is maybe decreased bioavailability in these patients who are very ill when you give the drugs orally. And that does not seem to be the case. There seems to be a difference, but it's not, and there's always a difference, of course, in the level and the exposure you can reach when you give IV or orally, but it did not seem to be very different from previous experience we did comparing IV and orally. And we just wanted to, With the IV, and that's also why I would give a patient in my ICU or our ICU in the Netherlands this regimen, we have the drugs IV available, and I'm sure that in that patient, if I give it IV, I will have good exposure, or I'm reasonably sure. So that's why, just to be sure, we use that IV, and we wanted to make it sort of a bit of a bolder step, let's say, and that's why we went for the 600 IV and compared it with the standard regimen. Your second question regarding drug resistance, we did not have any rifampicin resistance in these 30 culture-confirmed patients.
Thank you. We'll take one more question, Di.
So, Di Gibb from London. So my question was amongst your survivors. So you had reduction in mortality, but did you also have a reduction in neurological long-term deficit? Because that's obviously an important question when you're thinking of having better survival following
No, that's an
meningitis.
excellent and very important question, because there's one thing which is very intriguing if you follow patients, and I mean these survival curves, they go up until 1 year, but if you continue to follow, and that was one of the sort of sobering findings from the Vietnam trial, there was an effect early on with corticosteroids, but if you keep on following patients, they followed them for 5 years, and there was actually zero effect of the corticosteroids. So after completion of treatment, there's ongoing mortality, and there's definitely a lot of neurological disability. This is definitely something we need to take a close look at.
Great.
Thank you.
Thanks again, Renaud. So now I'd like to welcome our last speaker, Tawanda Gumbo from Baylor University in the US and Texas. And Tawanda's going to help make the link between the topic of this symposium and the theme of the conference. And he'll talk about adjunctive therapies and other approaches to extending the useful life of rifampin. Thanks, Tawanda.
So, thank you. Sorry? Yes.
It might just take a minute.
Okay. So I wanted to change things just a little bit. We're still on the same theme. I'll start with a little bit of work in the lab and then go to clinical data on the use of rifampin and, in fact, all first-line drugs, extending their use via a number of tricks. So I actually wanted to start with this rather controversial statement here, which is that drug resistance is a process, not an endpoint. Evolution is a process, is not an endpoint. And bacterial resistance is an evolutionary process. So, and there are several mechanisms that make us lose these drugs, like rifampin. And this is it's common to all first-line drugs and an emerging theme. This is common to all second-line drugs as well. So I'm going to start with a little example, adventure in the hollow fiber with ethambutol, and we'll get to rifampin very soon, where what we did is we were working in the hollow fiber system and giving ethambutol monotherapy. This is way back in 2008. This is published 2010. And essentially did a very simple dose response with ethambutol in the hollow fiber system and examined ethambutol monotherapy for resistance to both ethambutol and isoniazid. Ignore this. These were just the experimental details, study details. We gave human equivalent doses going all the way to about 100 mg per kg of ethambutol, very high. So you get a very beautiful dose-response curve that looks like this to ethambutol, and it actually turns out you get exactly the same early bactericide activity as in patients in this system. But this is the interesting slide and the first important point, which is you get this prototypic U-shaped curve of dose or concentration versus size of drug-resistant subpopulation, not only to ethambutol, but also to isoniazid, which the bacteria had not seen. Right? So illustrating a very simple concept in efflux pumps and efflux pump induction. You don't need the particular drug to induce efflux pump-based resistance to itself. Other drugs can do it for it, right? So you can ruin rifampin from use of some other drugs. That's essentially the lesson of ethambutol. These are very promiscuous kinds of pumps, and if you think of it evolutionarily, it's not going to be possible to make one pump for every chemical, all right? Can make one efflux pump for every conceivable chemical, so the efflux pumps that are there tend to get rid of a lot of different small molecules. And in fact, when we went back into these hollow fiber systems and gave isoniazid doses, and here is the early bactericidal activity here. Oops. The early bactericidal activity here with different doses of ethambutol. And you can see that this is with standard dose of isoniazid. And these are the prior doses of ethambutol that had been given. And you can see, in fact, in the ones that had not been treated with ethambutol, the isoniazid was as effective with an EBA that you would expect. And that kept falling. Essentially, there's also a dose-dependent induction of these efflux pumps. So, in fact, we have generalized this model and said, when you get drug resistance, it's what we call the antibiotic resistance R of time, and tolerance. So if you get all those different mechanisms, they're mechanisms for survival, all right? So we usually focus on the end point. You get a RipoB mutation in the end, but there are lots of events that have happened before. And these events include induction of several efflux pumps, not just one. In this particular study, we had about 4, and in fact, if you do RNA sequencing, you find there are many. Some we have heard of, and some we have never heard of. And, but in the end, these are all survival mechanisms that help the bacteria survive. So what is it that's interesting? So when you start antibiotics and poor dose, or that has been discussed before, especially in the case of rifampin, where we've been a little ginger in our dosing. Essentially, you unleash a series of events, including induction of efflux pumps, and you get demonstrable phenotypic resistance. That's reversed by efflux pumps as you go through. And if you wait long enough, sure enough, you get more drug-resistant usual chromosomal mutations in the genes that we're all familiar with, CAT-G, RipoB for rifampin. So it's a series of events, and the question is, so here on your dose, which is where you can act, all right? So it's going to be better to start with a high dose, and here, where you can intervene before everything goes wrong. So, and this is a look at, this is isoniazid, and you'll see rifampin just now, where if you have the drug alone, and we're just looking at mutation prevalence, or drug with one efflux pump inhibitor, rifampin, another one thyroidazine, a third one verapamil, which most people are familiar with, you actually get, right in the beginning, a reduction in the number of drug-resistant mutants. You see the same with rifampin, not as pronounced, but a lot more with thyroidazine, about a half-log reduction in your drug-resistant mutants. So even going in, the prevalence of mutants that you get will be affected by these efflux pump inhibitors, including a lot of the common drugs that are used for other things. And this is, I won't spend time on this. There are a number of pumps. Some are more famous than others. Most are proton motive force driven, which in fact, I'm not going to go into it, but if you look at the efflux pump inhibitors we were talking about, most of them in fact act over here. It so happens, somebody was talking about meningitis in a few minutes ago, that in fact, these are very similar to your usual ABC pumps and other things that act on the blood-brain barrier and efflux antibiotics. So you can actually use the same strategy to inhibit the effect of the blood-brain barrier and increase concentrations of your antibiotics. So I'm going to go to this first So this is a study we never published, but we've shown around quite a lot. So if you increase rifampin exposure here, measured as AUC to MIC, right? So as you go up, you get your usual dose response, which other speakers have been alluding to. You keep increasing your AUC to MIC, you keep seeing a higher effect. Now, this is in non-replicating persistent bacteria that are under anaerobic conditions. Now, if you add, so these are not replicating bugs. If you add verapamil, one efflux pump inhibitor, or thyroidazine, or rifampin, or rifampin, you get this further enhancement. In fact, you get better sterilizing effect. And essentially, the way to think about it is this shifts your dose response curve to the left, right? So you can use lower exposures that are clinically achievable by adding the efflux pump inhibitor and accelerate your sterilizing effect. And these are just the exposures of thyroidazine, verapamil, and rifampin that we have used. Here's a simple combination experiment, and then I'll show you some patient data. In vitro. And essentially, here what we're doing is, if you give standard therapy, rifampin, isoniazid, pyrazinamide, that's what we give. You get, these are non-replicating persisters, so you get kind of a very slow kill, right? If you add each one of these inhibitors, this is just linear regression here, you get more and more faster and faster sterilizing effect, even at standard dose. This is semi-dormant bacteria, same effect. And in fact, even for log phase growth bacteria. So if you do experiments in the hollow fiber, you then find that you can actually accelerate your time to extinction of these different Mycobacterium tuberculosis population by adding thyroidazine, rifampin, and verapamil. In other words, you can accelerate, you can shorten therapy. So here's an illustration. We have a database of TB patients in Texas with records that have been computerized by a lot of my predecessors in the state. And there are a number of patients, especially from North Texas, where sputum was collected each week until negative sputum. So what we did is, some of them had hypertension and other things, and we did a very simple case control study of patients with tuberculosis treated with standard therapy who were on verapamil and those who were not. And we've done this with a few other calcium channel blockers. This is a small study, but in fact, the numbers go into the hundreds if you choose specific type of calcium channel blockers that are also efflux pump inhibitors. Always sputum positive TB patients, and essentially we examined time to negative sputum and proportion with negative sputum at 2 months. So here's your number of cases here of who were on verapamil that we chose. There were 11. They were older than our controls, to be expected, since there are reasons why people get put on verapamil, and metabolic syndrome and some diseases as people age. Cavitary disease was actually more common in the cases. The controls were patients with TB who were treated with standard therapy who did not receive verapamil or any other calcium channel blocker. They had more diabetes. This is because, of course, we give verapamil for a variety of complications of the metabolic syndrome. So this just tells you the type of patient who is on verapamil. And of course, more arrhythmias, same reason, and hypertension. So this factor, for example, would of course mean that you expect more failure in patients in the cases compared to controls, just because there's more diabetes in that population. So here's your sputum conversion here in the patients. Here are your cases, very dramatic decline. a median time to sputum conversion of a few days. And here is your log P. And you can just do 1 over 0.07 here to get your odds. In fact, we have, as I said, now looked at a few other calcium channel blockers that are in the subclass with verapamil. And in fact, all of them tend to do that, not to the same extent, to different extents, but it's not just verapamil that will do that. So, these are just your further stats here. If you looked at proportion of negative sputum, which was 90% at 2 months versus 54% without. I didn't include another exercise that we did, which is, so if you increase doses of rifampin in the face of efflux pump inhibitors, what do you get? You actually get even faster conversion. And if you increase doses of rifampin beyond 600 to 1200 and increase doses of pyrazinamide, which is synergistic with rifampin, you get even faster conversion in the presence of efflux pump inhibitors. So if you remember the other slide that I showed of your non-replicating persisters on standard therapy, that you tend to get more rapid decline in bacterial burden for standard therapy with all 3 drugs. And as you optimize the doses of each, you get a faster and faster kill. We have a mouse study that we did that I'm not going to show, but the intent of that was to look at verapamil and thioridazine concentrations that are achieved in the lungs of mice. And what you see is that the thioridazine, because of lysosomal trapping and other things, tends to be concentrated higher in the lung than what you see in the serum. And this is important because you can't really push the dose of thioridazine that much. In fact, when we did, mice start acting very funny. You can imagine what would happen to patients. There seems to be lots more room for verapamil and calcium channel inhibitors, and they have fairly good concentrations in the lungs. We actually also measured rifampin concentrations in the lung, and it's a much harder molecule, and the pharmacokinetics are very messy in the lung with rifampin, and so we sort of haven't resolved what you can do with the doses of rifampin. I'll stop there.
Great. Thanks so much, Tawanda. I think in the interest of time, to make sure we have room for the full panel discussion, I'll ask the other speakers and my co-chair and co-organizer, Patrick Phillips, to come up. And we'll all have a discussion. There'll be questions for you, Tawanda, as well as for Kelly and Jerry and Reinout. Go ahead.
While you're organizing.
No, go ahead. Yeah, that's fine, Bob.
Okay, so the data on verapamil and calcium channel blockers is quite interesting, but the trouble with looking retrospectively at time to culture conversion data is that you don't really know that everyone was sampled at the same time in the same way, and that could affect your conclusions. The days, for example, that people had sputum cultures obtained. And my specific question is, going back over that very long period of time, probably the culture techniques changed so that they were, and so the question is, were they mainly solid culture at the beginning of that period of data collection and mainly midget cultures by the end?
Yes. So these were liquid cultures. But yes, no, I totally agree with you. I think it's what we could only do is a retrospective look. So we chose these. There were more patients who were on verapamil, but we chose these because they were on weekly sputums as much as we could. But yes, there's no way to deal with some other internal biases and problems of retrospective studies. So I totally agree.
But they were all liquid culture then?
They were liquid culture, yes.
So I'm going to move on to the panel discussion now. I'm very pleased that we have some very experts in vitro studies, in pharmacology, in the clinical trials and the clinical outcomes, and know a very great deal about high-dose rifampicin. I'm chairing the panel discussion to allow the chairs to actually participate fully in the discussion. So I would really solicit questions for the panel, so please do come up to the microphone if you can. If you can't make to the microphone, I'm sure you can shout from where you're sitting. If this is a question for the panel, please go ahead.
Well, it's a comment, not a question.
Okay.
I'd like to say first that there's very good evidence that efflux pumps are induced before antimicrobial exposure, and resonance in macrophages induces efflux pumps. The second thing is that there is a considerable pharmacokinetic challenge of using these efflux pump inhibitors at the concentrations that were used in vitro. For example, the concentration of rifampicin that's used in this, if you achieve that level in man, you'd kill them. It's just a little more complex, I think, is my point.
I totally agree. In fact, it's not just calcium. It's not just residents and macrophages that induces this. In fact, what got us to look at efflux pumps was you actually induce efflux pumps in bacteria by changing the physical-chemical conditions around it. A low pH leads to induction of several efflux pumps that have to do with proton motive force. Hypoxia itself induces certain types of efflux pumps. And in fact, the phenotype that you get has a lot to do with efflux pumps, among other things, right? So yes, and in fact, I didn't show, I have in backup, in some of the backup slides. So why I put it just as these are anaerobic, these are log phase, this is because the conditions themselves induce efflux pumps. And you can actually show with ethidium bromide and efflux pump inhibitors that you get different changes. So it's not just macrophages. In fact, it's the physical-chemical conditions around that change it. That being said, I think the challenge is pharmacokinetic. If we can give enough, that's why we went looking for many different calcium channel inhibitors. If we have chemicals that will be able to get to the lung in sufficient concentrations, and calcium channel inhibitors are the best candidates, then even without antibiotics, when you put efflux pump inhibitors and bacteria alone, there is some killing, even before you add antibiotics, because this is a survival mechanism.
I wonder if I could ask a question to the panel. Well, please do come up if you can. I've been told that we should try to use the microphones because this is being recorded. We've seen really compelling data about high-dose rifampicin, and it almost seems scandalous that a suboptimal dose of rifampicin is being used today. I wonder if any of you could comment on what do you think are the next research studies that we need to do with high-dose rifampicin before this can be rolled out into program settings. And there is, if you could pass the microphone down. Oh, there we are. There's a microphone.
Yes. So I think that everybody in the room has come to that conclusion that, and some like Chuck and others got there 2 decades earlier than most of us. But we are using low doses of rifampin. There were reasons why that developed at that time and how much drug we had. So the dose was chosen for pragmatic reasons. Now we have more resources to do this. I think the safety, so high dose rifampin studies and high dose of the companion drugs to optimal dose. And in fact, and I'll let Kelly comment on this, high dose rifampicin. So I think you have to dose all these appropriately. And the next set of studies are very simple head-to-head comparisons in my head of high dose for safety, which is what people have been afraid of. I think we worry too much about it because we can monitor. I'm not saying there isn't going to be toxicity, but we can monitor, right? And high-dose isoniazid push up the dose of rifampin considerably more and push up the dose of pyrazinamide, and I know people have concerns of hepatic toxicity. But I would do a high dose of all three versus standard therapy and look at efficacy and follow them for toxicity and see maybe it's justified that high doses give you more toxicity. I think we may probably pass that.
Okay. Any others?
So I would say, I think the question really is how much is enough. So I think what we have now in our hands is definite evidence that at least one higher dose produces greater efficacy. I think the difficult question is, at what stage do you take that through into definitive trials, phase 3 trials, and what other dose optimization should or shouldn't be done before that happens? I think from a patient's perspective, we have difficulties calibrating phase 2 trials with phase 3 trials, so we can't really predict perfectly what the duration would be, but we can make a pretty good guess. And I think if we already have on the table a dose that looks like it could bring about a 4-month regimen, that's a dose we need to urgently study. But at the same time, I think we also need to keep evaluating, higher doses, because if that trial should fail, we need to have a backup plan.
Question here.
Yeah, so maybe if I let Carol speak and then I go for the question, sorry.
Yeah, I just want to add one thing. I think that the emphasis, at least for pulmonary TB to date with higher doses of rifampin, has really been treatment shortening. And I think one of the things that is on the table here as well is improved efficacy, and whether that's efficacy in improved efficacy in the presence of RIF-tolerant organisms, or there's some very preliminary data from a study of high doses of rifampin in an HIV-infected cohort where the high dose of rifampin seemed to have a survival benefit. So there may be other questions that we need to pursue with high-dose rifampin, not just shortening questions, and I guess then it becomes more important or equally important to try to understand who needs those higher doses, and so the question about what is the role of therapeutic drug monitoring in treatment of TB, even in resource-poor settings, becomes an open one, and how might that be integrated into some program settings to identify patients who could benefit from higher doses.
And if I may add one small thing, I would favor doing studies in different settings. I mean, the exposure we get in Indonesia with the similar dose of rifampicin compared to Africa is very different. Mm-hmm. And so high dose in Asia may not necessarily be the same as high dose in Africa.
Can I add something?
Okay, sure.
Yeah.
Thank you.
Because I've got very distinct ideas about this. First of all, I don't think we should make the mistake we made 40 years ago. I mean, 40 years ago, rifampin was introduced 10 milligrams per kg for the obvious reasons. And now we sort of have 35 milligrams, which is sort of some kind of a magic dose, and it's now evaluated, and people are now talking about 35. But this 35 was just coincidental, because we were doing the study until 35, and then we were stopped because we ran out of funds. Right. So I think that study needs to be finished. So we already did 40, and 40 is actually quite safe and has the same effect. And I presented that on different occasions. But we now are also going to do 50, and actually we also have an application going to even go higher to 75 and 100 milligrams per kg, which sounds very, very brave. But again, you only find out toxicity if you do it in the patients. Now we know in modeling that if you increase the dose from 40 to 50, the expected increase will be about a 50% increase of AUC. So we'll see what happens in these patients, and we've got very strict safety rules on that. And if we determined the maximum tolerated dose, then we take it backwards again. So we'll then evaluate in larger trials, like we did in the MAMS trial, for a longer period, whether the same issue is happening. Is it efficient, but is it also safe, and is it well tolerated? And if you then identify it for a phase 2 trial, let's say the more ideal high-dose rifampicin, in combination with companion drugs, then you'll take it to phase 3. I think that's the way we should do it.
Okay. Thank you for your patience, if there's a question there.
Yes, just to backtrack a bit, Chikodi from Nigeria, to Kelly, who has been able to do some in vitro studies. If there is any, as we are ramping up the dose now, what's the interaction with cardioactive drugs, because we have people who may have some other cardiovascular conditions are taking some medicines. If she has anything from the literature or any modeling on those interactions. Thank you.
Yeah, no, that's a good question, and I was thinking about that some when Tawanda was talking about verapamil and other drugs that might potentially be useful as adjunct therapy for TB. So, you know, if you give verapamil together with rifampin, you reduce the concentrations of verapamil significantly, and so it's always this challenge of you find maybe an alternative therapy or some sort of extra drug that might be somewhat helpful, then you know what is the impact of rifampin and higher doses of rifampin on those drug concentrations? And then there's always, you know, it's not even just what the concentrations are, but the therapeutic margin. So if you reduce the concentrations somewhat, then how does that impact on the effectiveness of that drug? Because some drugs have, you know, narrow therapeutic margins and others have wide therapeutic margins. But yeah, so you know, in a patient who in his cohort's taking verapamil and is probably taking Lipitor or some other, you know, medicine, and is also taking metformin for their diabetes. I mean, all of these drugs have immunomodulatory effects and actually are decent TB drugs that people think have some possibility as host-directed therapy. But then you give those drugs together with rifampin, then what indeed happens to them. So I don't have the answer for specific drugs, although I mean, they're about higher doses of rifampin. I think a lot of studies have been done for diabetes drugs and hypertensive drugs and standard dose rifampin that are published, but that's all.
Okay, thank you. Next question, please.
Two simple questions. The high-dose rifampin, you showed the 2-month culture conversion rates were very promising. Do you know anything about relapse of those patients? That's the first question. I know it wasn't powered to look at that, but just wondering. And then the other thing is on drug interactions with rifampin, or rifapentine with the quinolones. And again, people may know, this is a simple question, people in the room may know, were the quinolone trials that were shortened, you know, the 4-month shortening trials where there was sort of an unacceptable relapse rate in those instances, were the quinolone levels measured and or lower than expected? And could that be a possible issue that could be examined? Because, you know, the 6-month rifapentine with moxifloxacin was acceptable in the continuation phase, and so there would be more exposure if you were kind of, you know, on the fence if the moxi was lower, for example, than expected. So.
Thank you. Do you want to take the first question, Martin?
Yeah, the first question, I can answer that. Yes, we did look at relapse rates, but again, this was small cohorts of 60 patients, and you have to remember that after the 3 months of experimental treatment, we continued with the standard treatment. So for comparison-wise, it's not a very reliable thing. But if we looked at the groups, the relapse rate were not too much in the 60 patient, and unfortunately also in the RIF 35 patient, there was 1 patient who relapsed. Yeah, well, yes, thank you. So it's actually Patrick who found a solution for that problem. This is so-called phase 2C step design, where we are going to, in our next design, we're going to look at arms and then stop after 4 months, and then follow them up for 12 months, so a total period of 18 months, and then we can more reliably say whether the relapse rate is related to the experimental regimen, and with the statistical approach, we can then make a prediction whether this regimen will be, let's say, comfortable in taking further to phase 3.
Kelly, do you want to address the second question? Thank you, Martin.
Yeah, I'll take the Moxie question. So actually, this is pretty interesting. So in Radha Savage's lab, she has a student that looked at the relationship between rifampicin dosing and moxifloxacin reductions in exposure. And so, so if you give, in some of these trials, moxi and rifampicin were given once a week, some arms twice a week, and then other studies have 3 times a week or daily, and found that there's a really nice relationship between the frequency of dosing and the induction effect on moxifloxacin. So moxi is metabolized by these phase 2 enzymes, but essentially if you give the drug once a week, there's not a lot of effect, but as you give the drug more frequently, then you have increased reductions in moxifloxacin exposures. So yeah, so there's the more you give it, and perhaps the higher dose you give, the more effect you're going to have. The problem is that I think, with moxifloxacin, we don't really know what the target is. So, if you reduce concentrations 50%, is that a good, is that a problem? What kind of AUC over MIC, are you aiming for? Is it 100 like with other bugs, or with TB is it something different? So without these targets, it really makes it hard to say, okay, we think this drug interaction will happen, therefore in the trial we should dose adjust and give, this particular thing. But she's also now going to be looking at the QT effect of different drugs and drugs exposures, because that's the thing people worry about.
Thank you. We're running a little bit over, but I think we'll continue with the questions because I think it's some fruitful discussion. If I can ask the questioners to introduce themselves before they ask their questions. Thank you.
Andy Vernon from CDC. I have a question for Reinhold. It's a very nice presentation. I recall, we know, of course, that when INH was introduced, one of the most striking aspects of its introduction was that it was so dramatically life-saving in pediatric meningitis. And so I'm wondering, is there a reason that rifampicin is the best drug to focus on in trying to achieve improvements in short-term mortality in TB meningitis? Are there other drugs that it might be equally important or even more important to look at in this regard?
That's a very good point. There's actually 2 reasons. One is, of course, that INH has a good penetration in the cerebrospinal fluid, and we might think that we're not giving high enough dose of INH generally, let's say, and it depends on the acetylator status. And second is that the data on the relation between drug resistance and outcome, and the strongest relation are for rifampicin-resistant TB meningitis. So in that respect, rifampicin is an attractive drug to start with, but I would not say it's the only one we should be focusing on.
The other issue in this regard related to rifampin, of course, is the issue of how you're doing drug susceptibility testing. Since using the current standard cut points, there are quite a number of rifampin semi-resistant strains, of strains that have elevated MICs that may also be playing a role in the poor outcomes.
No, that's a very valid point, and there was a very nice workshop yesterday where Scott Hazel explained the and actually methodology which is implementable in this also in a setting like Indonesia to get MIC values and to actually do the calculation of AUC MIC. Yes, thank you.
Maybe, Andy, one addition on that. Actually, I started to treat 2 patients on that with the intermediate resistance, and they actually do very well with high dose, and I go to 2,100 milligrams with good AUCs above MIC. So you can do it in practice as well.
Thank you. Okay, Tawanda, if you want to add anything.
Yes, so it's actually a great question. So when you get above rifampin MICs of 0.06, you start seeing a milligrams per liter, you start seeing a diminishing effect. But that's with the standard dose. And in fact, for AUC to MIC-driven drugs, you can literally compensate by going up as well on your dose. And as long as patients can tolerate it, you can treat a lot of those in that intermediate zone, but you have to go up considerably on your dose to compensate for the increase in MIC.
Okay, thank you. So there's 3 more people there. I think if we can take these last 3 questions, please go ahead.
Anthony Byrne from Australia. Thank you so much for the presentations. This is a question for any of or all of the panellists. if we know that in some people that standard doses of rifampicin result in sort of lower doses in the lower concentrations in the plasma and even lower concentrations in caseous parts of the lung. If we now know that higher doses, such as 35 milligrams a kilogram, are well tolerated and don't have any increased effects, and it's possible and plausible that low concentrations might result in resistance, in the development of resistance, should we not now start using higher doses of rifampicin as a standard practice?
So if I could ask someone who would like to respond to that, maybe we haven't got time for all of you two. Who would like to take that question? Jerry?
Should start.
Oh, Tawanda?
Yeah, so I think that so there's what Martin outlined, which is let's increase the doses and look at comparisons in terms of demonstrating real outcomes. I am actually very comfortable with starting with higher doses in clinical practice, especially depending on your MIC spread where you are. And I'm going to and depending on the site of infection. For example, when we looked at in standard therapy at drug penetration into the pericardium in TB pericarditis, there was virtually no rifampin, like 0.1 of what you would expect in actual patients. So, and the mortality rate is very high in those patients with TB pericarditis. I have no hesitation in starting with high doses. It's a risk-benefit thing. So in sites where we know that the rifampin doesn't enter anywhere, and in situations where we know that our MICs are in that intermediate zone, I would in practice start with that. But I think there is need to have well-controlled studies to answer that definitively.
Okay. Yeah, I think I would just add that clearly that's something we can do in the lab, is to demonstrate, the relationship between concentrations and resistance. That's much more difficult in the field and indeed in trials. So we barely look at the impact, on resistance generation in trials because it's difficult. And so I think in terms of recommending a programmatic dose, that's a tough one, because epidemiologically proving that it's associated with a reduction in resistance is very, very hard. And I think getting that through a guidelines panel would be challenging. I guess that would be my view.
Yes, I will go first. One other thing I just wanted to say is that I think in TB we try to use one-size-fits-all medicine, and so for a patient with diabetes, no matter where you are in the world, you're going to get a different treatment regimen depending on your severity of disease or how poorly controlled your sugars are, and so not everyone is going to get the same dose of insulin. Not everyone's going to get insulin at all, right? And so, but with TB we kind of say, well, everybody should get the same dose, and it's programmatically easier to give the same dose to all of your patients, but it's very likely. These phase 3 trials of new TB treatments or shortened TB treatments, they fail because the hardest to treat patients relapse, but the average patient does very well in all of these trials, and most people could be treated for 4 months and stop and do very well. So I think I wonder as time progresses if we're going to have better ideas of those people who are likely to need a higher dose in order to do well, and be able to identify them at the beginning, and then use a treatment that's somewhat personalized, at least in some groups of patients.
Thank you. I'm sorry, Martin. I'm going to answer the next question because these two people have been waiting very patiently.
Dave Jacobus, I'd like to ask Dr. Van Krevel and the panel whether the pediatric model that he described is the ideal place to do our high-dose pharmacology.
I'm an adult physician, so I hand over the question to Kelly.
Yeah, I think right. So if you think about TB meningitis, then the people who get TB meningitis and die from TB meningitis are children 0 to 5 and then older adults. So if you want to study the population that's most likely to benefit from the right dosing, then children is a good population to study. And then within children, the way that children the drug concentrations in children and the handling of drugs in children is very age dependent, and so it's an interesting place to study pharmacology of TB drugs, because a child who is 0 to 2 or a child who is 0 to 2 to 6 is going to have very different drug concentrations for the same milligram per kilogram dose, depending on their development of their metabolizing enzymes, development of their kidney functions, and things like that. So I think it's a good patient population to study for pharmacology if you have developmental pharmacology models that will help you understand. Okay.
My question dealt with ethics, availability, speed of end. These kids are going to die. Every percentage of them, I understand, in a week.
Right.
Got to get their dose up there.
Oh, right. So why wait to study it? Why not give all children with TB meningitis?
The study we did was not powered for mortality. I very much appreciate the point. The study we did, we saw a very big effect, and that's why it was statistically significant, but it wasn't powered for mortality. The sad thing, after the Vietnam trial, I was in the US and I learned from US physicians that they had actually started using more intense and higher dose treatment, and that after the New England trial they had reverted to standard treatment, which I thought was very sad, because that Vietnam trial was just underdosed. They didn't know when they designed that study. I couldn't hear what you were saying. Sorry?
You're asking, is he currently doing a bigger trial?
Well,
Higher doses, yeah. So Reinhard, higher doses? Do you propose higher doses?
Yes, I would definitely, like I say, if it would be the next patients we treat in our setting, we definitely give intensive treatment. Our data were considered, and we had a discussion also with Lancet ID on how to phrase the conclusion, for instance. It's not strong enough evidence for people to change a guideline. For me, it's strong enough evidence to change what I'm doing. And I think for some of us in the room.
Aren't we here to have a discussion to change the guidelines?
Well, based on these data and with the large study from Vietnam, that's tough. And I think, and I really think that it would be great to do a study with a more aggressive, so we opt for a 20 milligram IV rifampicin dose in a predominantly HIV-infected population in Africa.
A beautiful study, but why not go up to the limit?
Well, maybe you can help me and talk to the people who write the guidelines. I'm afraid that I think funders.
Yes. Thank you. I wonder if I could. I thank you everyone for being very patient and waiting. I wonder if I could have the last question, and then you'll be free to go and have your lunch. Thank you very much.
Yes. Hello. I'm Judith Brockfeldt, infectious disease physician from Karolinska University Hospital in Stockholm. So it's a question for Rob Arnotze. I recognized your choice of a regimen for TB meningitis. We would actually do pretty much the same. But I'm wondering regarding the evidence for the quinolones, since at least in the trials you haven't been able to show any effect of either low or high dose Moxi, and why also omitting ethambutol in high dose, which can also be given IV.
No, that's a very good point. The Vietnam trial didn't show an effect of levofloxacin added to the standard regimen. The earlier Vietnam work showed a U-shaped relation with higher quinolone concentrations. So there is questions out for the fluoroquinolones. I totally agree.
Yes, and also some worries regarding toxicity with these very sick patients.
Yeah. I think we should start to look also at pyrazinamide. There's a rumor that pyrazinamide concentrations are associated with mortality, and actually that's also a good question, and we already addressed the issue of INH, so it will be another few years before I can finally work on host-directed therapy.
Yeah, okay, thank you.
Well, thank you very much for the discussion. Please join me in thanking our excellent speakers for the discussion this afternoon.